Good evening, everybody. Am I audible, sir?
Yes. Welcome, Dr.
Uh,
Anupam.
I welcome all of you to this uh, faculty lecture. Uh, for chairing and moderating the session, we have Dr. P.A. Muhammad Kunju, who is from Kerala, and he is a well-known neurologist and expert on developmental pediatrics also. And along with that, we have to give the psychologist perspective. We have Dr. Roma Kumar, who has been associated with us, that is Gangaram Hospital, for the last more than 32 years. Um, and I would request Dr. Kunju to please introduce Dr. Sharmila Mukherjee and start the program.
Okay, thank you, Dr. Anupam. As I was telling in the initial phase, thank you very much for inviting me to this prestigious faculty lecture from Delhi. I'm happy that our Delhi colleagues, Dr. Alok Bhandari, President of IAP Delhi, and Secretary Dr. Mukesh is also involved in this. And I'm happy to welcome the speaker, Dr. Shamira Mukherjee, and she is from Lady Harding Medical College and director and professor of pediatrics. So she'll be speaking on autism in office practice, a stepwise clinical approach. And we have the moderator, Dr. Roma Kumar, senior consultant psychologist, as already Dr. Anupam has introduced. She is from Sir Gangaram Hospital with a vast experience. So I request initially Dr. Roma to start the procedure, the moderations, and then Dr. Shamila can start her presentation. Dr. Roma Kumar.
Thank you, Dr. Kunju. Thank you. And thank you, Dr. Anupam, for getting us all together on this platform. And I would straight away request Dr. Sharmila, with her vast experience, to start talking on the subject, and let's get going on that. I'm sure we'll all not waste more time, but let's just get connected and let's understand this whole area. Thank you.
Thank you so much. Just give me a moment to organize my screen. A very good evening to everybody. At the onset, I'd like to thank the organizers, especially Dr. Anupam Sachdev, for having invited me for this faculty lecture. And I really appreciate the time given by Dr. Kunju as well as Dr. Roma Kumar to be a part of this. So today I'm going to be talking about autism in office practice, a stepwise clinical approach. And this is directed to general pediatricians. It's not for developmental pediatrics or people practicing developmental pediatrics. It's completely in entirety meant for general practitioners. So all of you must be familiar with these pictures. And out of all of these national and international films and TV serials, the oldest is the one on the right, which is Rain Man, that was released in 1988. And since then, in the 1990s and in the last decade, there have been other movies, stories, which portray characters with autism. And it has served a dual purpose. One, it's shown that the prevalence of autism is definitely increasing, and that's why it has also led to awareness of the public by virtue of these characters. And the second most important thing is that lots of parents, families have recognized symptoms, manifestations in these characters and identified them with their own children and have brought forth these children to seek medical attention. And that was especially seen in India after this little girl was shown in a TV serial called Apna Antara. So in this session, what we're going to be discussing is an overview of autism. When should a general pediatrician suspect autism in a child? How to make a clinical diagnosis and office practice using a comprehensive systematic strategy. And I'll be using a case study to help elaborate this. I'll very briefly touch upon the multidisciplinary management of ASD, primarily to sensitize the general pediatrician, not to teach the nitty-gritties. What are the roles and responsibilities of a pediatrician for families with ASD? And if time permits, how to screen for autism in asymptomatic children. So look at the figure on the right. It's overwhelming, right? So many circles, so many text boxes, such a lot of information coming under one umbrella of clinical manifestations in ASD. No wonder any pediatrician can get, feel that this is not my domain at all. Let's just send this child. This child appears a little unusual. Let me send this child to the developmental pediatrician. So my purpose of this session is to dispel the mystery, simplify this, and bring it down to things that are concrete and operational. So the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, which we all refer to as DSM-5, defines autism spectrum disorder as a neurodevelopmental and behavioral condition of childhood that's characterized by 2 core symptoms. Now, these 2 core symptoms are those little blue, dark blue ones in that figure. One was a deficit in social communication, and the second was the presence of repetitive restrictive behaviors, interests, activities, etc. In addition to this, the clinical manifestations basically are 3 core categories, 3 categories. One, the core symptoms that I just outlined. Second, unusual, atypical behavior and play ensuing from that behavior. And 3, the manifestations from that arise from the very common comorbid conditions that are associated with autism per se. And all of these lead to age inappropriate abilities. And that is why it's also called a autism spectrum. So why is it a spectrum? So obviously, if you can understand these 3 categories of symptoms, and you have numerous numbers of combinations and permutations, it leads to a very wide spectrum. And that is why the rainbow is one of the symbols. Rainbow colors is a symbol of autism. And these manifestations can be on one extreme, severe disability. That you can see here, this little boy on the right, we'll be talking about him, we'll be discussing his manifestations a little later. And you'll have on the other extreme, all of you are familiar with Shah Rukh Khan's portrayal of the character in My Name is Khan, who has extreme ability in some areas, but has impairment in other areas. And you also have children who are somewhere in between, average ability or mild disability. So there's a wide spectrum ranging from one extreme to the other. And the reason why you have this infinite rainbow symbol is because this means that there are infinite manifestations, but alongside there are infinite possibilities and solutions for intervention and managing these manifestations. So let's proceed. So this is, let me familiarize you with the clinical diagnostic criteria of DSM-5 for autism spectrum disorder. You remember during the pandemic when the criteria for MISC came out? The first time I saw it, I was overwhelmed. I felt that how on earth am I going to remember these criteria and how am I going to get them done? So it's the same for this. A general pediatrician might feel, yeah, this is not my cup of tea, but it's pretty simple. And I'm going to simplify it for you further by showing you examples. So all you have to do is you don't have to memorize them, understand. And then whenever you need to apply them, all you have to do is just do a Google search and you'll get them on your hand, on your mobile phone. So there are 5 criteria, namely A, B, C, D, and E. A has 3 criteria, sub-criteria, and it includes persistent deficits in social communication and social interaction across multiple contexts as manifested by all of the following, currently or by history. So I'm going to go to each 3 of them, but I want you to focus on a couple of things that I have highlighted in black font. So the first is these key phrases, persistent. So persistent, pervasive, which was used before in the earlier nomenclature. The second is across multiple contexts, which means it's not just done at home. It's done at home, at school, at play school, in the playground, everywhere. And the third is currently or by history, which means these manifestations may be present at the moment, in the moment right now, or may have been present before and has now changed, but was there earlier. So let's go to the first one, which is deficits in social emotional reciprocity. So you can see here this boy. This boy is a 5-year-old, and just look at his expression. Look, it's a blank face, and he is in his mother's lap. And when we talk about social emotional reciprocity, you all understand reciprocity. Reciprocity means to and fro, like serve and return, like in badminton or in tennis. So I initiate something, the other person responds, and then I respond to the response that he has given me. So in a social interaction, the emotional behavior of an individual related to the context, related to the situation in that occurring in that social interaction, that is either absent or it's decreased or it's age inappropriate. So this refers to social interactions, the social approach, the conversation, the to and fro progress, how the child or the affected individual shares his interests, his thoughts, his feelings, ideas, emotion, and also includes imitation. So let's see what we can see in this video.
अच्छा बात कीजिए उससे चुमो दीदी हेलो दीदी हेलो
चुमो
हेलो हेलो
चुमो
जे जे करो बेटा जे
आजा आजा चुमो आजा
जा पापा
आजा
पापा
आजा आजा आजा
जे जे करो बेटा जे करो जे कैसे करते हैं जे करो जे हाँ जे और थोड़ा ऊपर हाँ जे
So in this video, the social interaction is one in the mother. He's in his mother's lap, and the mother is asking him to do jai jai, which he did after some period. He's not making eye contact. He is following the instructions to a certain degree. And the father also, if you realized, he had extended his hands like this. And any child, if he sees that, will also kind of reciprocate by doing that. The child disregarded the father completely. So there was definitely age inappropriate and definitely a muted social emotional reciprocity displayed by this child. Now, as we go through each aspect individually, I want you to also look at the aspects that we've discussed in the fresh video of the child, because obviously all these children are going to be displaying multiple manifestations at the same time, and it's the your competency to catch all those things. So the second criteria in A was deficits in non-verbal social communicative behaviors. Again, it is pretty explanatory, self-explanatory. In a the non-verbal communication that is used in any social interaction, and you can see the things that I've listed on the side: the facial expression, eye contact, gaze avoidance. If you don't want to make eye contact, you look in the different direction. Gestures, gestures to ask for something. Oh, I like that sari. Can you give it to me? Or show. Oh, you know what? That sari also looks nice. I may not buy it, but can you show that to me? So the use of these gestures and the response when somebody else uses the gesture, suppose the mom says this, does this, or aakhe dikhana, which is a very, very, very common mom gesture. How does the child respond? And there are certain atypical gestures, something which we call hand-on-hand pointing, which means that the child will grab the hand of his parent, pull the parent to the place where he wants his he wants whatever he wants, and then he will use the parent's hand as a tool to get the object of his desire. So that is a pretty pathognomic gesture that is seen in children with autism. And then the general body language, the way the child will be leaning in, the kind of posture, position of the child while he is engaged in a social interaction. Now, this video is of a pretty young child. It's a 10-month-old girl who was brought by her parents because they felt she had, the child was not responding to them.
बात करती जाओ। अब आप आके बात करो, छूना नहीं है, सिर्फ बात करो।
हाँ हाँ ठीक है ओए हाँ
So you can see the same thing when the baby was in the mother's lap, the mother was like trying to get her attention. She did not respond. The father also kept on calling her. She just looked for him for a momentarily, and then looked away, was not interested, and there was no change in the facial expression at all. So the eye contact is poor, and the facial expression is monotonous and not appropriate to the context. The third is deficits in developing, maintaining, and understanding relationships. Now, this is pretty clear from the language used in the terminology. So it refers to the relationships with peers, with friends, family members, siblings, whether the child reciprocates, whether the child rejects or is passive. It also extends to the pretend play and solitary play. And it also translates into how the child can understand how to, sorry, just a minute. How the child can talk or behave in context with the situation where the child appears to be. So that is, let's look at the first video. Let's see if you can guess which child is the child with autism. There are 3 children here. So you can see here that the child is kind of slightly interested in the game. She goes there, stays at the periphery, and comes back. Doesn't actively participate. Now, this is something that, like, when you're going to try eliciting history from the parent and you ask the mother that does your child play with other children? I mean, if you look at this technically, yes, the child is playing with other children. But is she? She's not actually. So that is why getting videos are very important to understand what is the actual reality of the situation. And let's look at this. This is this boy playing with his didi. So you can see here, the elder daughter is looking at her brother, trying to, like, she's actively involved in this circling, running around, running in circles game, whereas this boy is interested in running, but and mouthing that remote in his hand, but he's not looking at the sister at all. He's not, looking, checking, okay, we're having fun. So that is, again, the history will come that yes, the boy plays with his sister, but in reality, it's not proper, functional, meaningful play. So the second criteria, we've covered A, that was deficits in social communication. And now we come to B, the presence of restricted repetitive patterns of behavior, interests, or activities as manifested by at least 2 of these 4 criteria. And again, the criteria, we're going to go one by one. So this is pretty clear: stereotypic or repetitive motor movements, use of objects, or speech. So this movement that is being displayed over here is classical rocking. So it can be side to side, it can be to and fro, anterior, posterior, it can involve only the head or the trunk or the complete body. Sorry. Again, this is the boy that we saw earlier, and you can see his repetitive hand clapping. Again, he just likes staring at the ceiling and doing these movements. Now we come to B2, which is, this is still the first criteria. We're focusing now on the repetitive use of speech. Now, communication in the diagnostic criteria comes under two subcategories. One is the repetitive use of speech, and the second is the ritualized patterns of verbal behavior. So the way a child uses this communication while doing ritualistic behavior. So I'm just trying to make it easy by clubbing both of them together. So one is stereotypic use of objects. So like, look at this. This is what we typically call lining of objects. The child will line the things. You can see here, these are balls, there are fruit, there's a duck in between. There's no meaningful play, but he'll put them, he likes the visual, like impression of things in a line, or it can also be evident as stacking or playing with a part of the toy. Around 30% of children with autism do not develop speech, and the remaining 70% have repetitive stereotypic speech in the form of echolalia. You all know what echolalia is, repeating phrases or words. Jargon, which is the use of a meaningless, nonsensical language that sounds, it has the regular kind of way of speech, but doesn't mean anything. And neologisms, that are certain words that are used repetitively for certain objects, which the parent will know. Like, for example, if I say that a toy car, and I call the toy car choo-choo. So my mom will know that if I'm saying choo-choo, that I mean that car, but nobody else will. So that is a neologism or a new word. Then you can have kids with more functional speech and vocabulary who may be speaking to oneself, while they're doing the activities of daily living, they're talking to themselves, excessive questioning, keep on asking questions, and talking on only restrictive topics. And the children who do not develop speech often have this make these guttural sounds, as evident here. So you'll say that, okay, but lots of kids make these kind of sounds when they're playing. Yes, true, absolutely. But the thing is that if they make only these kind of sounds and no other sounds, a child who is really roughly around 3.5 years old, then that is definitely a problem. Now, the next criteria is insistence on sameness, inflexible adherence to routines or ritualized patterns of, as I mentioned earlier, verbal or non-verbal behavior. So this child, again, is a 5-year-old whose ritual comprises of picking up a notebook. It can be any notebook, and flipping the pages from the front to the back, and then turning the copy over and flipping it from the other side. And you can see there on the mattress, there are other toys that are present over there, that this kid did not play with any of the toys. He just kept on playing with this notebook. Now this other kid, he is around 2 years old. This is his grandfather. Whenever the grandfather comes home from his job in the evening, he just has to take some object which the grandfather gives him and has to go and put it in this drawer. And then he will go and insist on getting onto the grandfather's lap. And it doesn't have to be just his body, it doesn't have to be up against his chest. He has to perch on the grandfather's shoulder. And if this does not happen, he displays a terrible temper tantrum. Now, this terrible temper tantrum which children display when their ritualized patterns are not complied with is kind of children. Yes, they are. are. But if you have a temper tantrum that is prolonged, extremely severe, can cause self-injurious behavior, is provoked by anything and sometimes by no reason at all, occurs very, very frequently, then it's definitely something that needs to be explored. Then the next criteria is highly restricted fixated interests that are abnormal in intensity or focus. So again, we have this child. I'll give one toy. We've given him a whole spectrum of toys. And he's we've given him raffles, we've given him a toy car, no interest whatsoever. Why? Because his fixated interest is this. He likes playing with paper. And playing with paper, he plays with paper for hours and hours.
तो ये ध्यान न दे, मुंह में न डाले.
हाँ पहले वो खेलेंगे उसको पूरा, ये फेंकेगी नहीं उसको.
Either
टॉयज को फेंक दिया, उसको मोड़ के मुंह में दे देगी.
Pack it or clap it together. And again, the kid looks at the screen all the time. So now we have the last criteria, which is hyper or hyporeactivity to sensory input or unusual interest in sensory aspects. So this is one which displays an unusual interest in if he sees a reflection, whether it's in a mirror, whether it's in a glass pane, whether it's in a puddle, and he has to gaze at his interest, at his reflection, and he gets extremely irritated if he's removed from that area. Now this boy, please remind, or you'll say that, okay, he's wearing spectacles, maybe there's something wrong with his eyes, and or maybe his refractory error is not corrected properly. But no, this child has undergone a refraction evaluation of his vision. It's absolutely fine with his spectacles, corrected vision. But I want you to focus on the way he looks at the object. He brings it closely to his eyes, or he looks at it from the corner of his eyes. This is one of the typical things. And I'll just excuse me for a minute while you look at the video.
ये क्या है? चलता है.
So can you see he's looking from the side? And now again, he's bringing it very close to his eyes. So these are visual aspects. Now I want you to see the tactile mouth, putting things in the mouth, which is very, very common in children with autism. This little boy puts everything he finds in his mouth. So we've talked about hearing. We've looked at vision. Also, this is hearing. So hearing hypo. Hypo is often that when the mother will say that he doesn't respond when I call him. So that is hypo responsiveness. Here we give him a toy. It's a sound making toy, and this child there's no difference. He's not looking at the toy. There's no change in his facial expression. He's just playing with his, he likes touching these grapes. That is his tactile thing. So there are two things that are evident in sensory aspects that are obvious in this video. One is this persistent tactile feeling of these grapes, and the second is the hyper-responsiveness to sound. Now this is for hearing. This is a very common complaint that comes, is that my child cannot tolerate any kind of loud noise, even noises that are heard in usual daily routines, like the whistle of a pressure cooker. So they immediately clap their hands over their ears. And this, what I'm showing you is again, hyper-responsiveness to sound, but it's unusual, and it's seen typically in children with Angelman syndrome, in which the moment you sound a frequency fork or you crumple paper, those sounds make these children, like go into peals of laughter. You can see before we took the tuning fork, his face was fine. And the laughter also, it's not laughter, you know, like that I find something funny, humorous laughter. It's something totally different, but it is laughter. And if we go a little ahead, we'll see that when we give him, we crumple some paper.
इस तरफ कर दो, ऐसे बैठो थोड़ा.
आप कितने भाई बहन?
You just have to take my word for it. So like in the previous crumpling of paper, the other boy was crumpling the paper for the tactile feel. Whereas here, this sound of the crumpling paper, which provokes or triggers of this reaction. And this is another video, which was a very difficult video to film. We're trying to display here, this boy likes to smell things. Anything that any object that he picks up, the first thing that he's going to do is going to smell it. So hearing, vision, tactile, taste, olfactory we've covered. Pain is something that often is a very common, pretty common manifestation. And one of the questions which I asked from a history that I got from a parent many years ago was, she said that my child, you know, in Hindi they say, बहुत सहनशीलता है. So for people in the South who do not understand Hindi very well, सहनशीलता means, you know, like tolerance for pain. You know, it's kind of something, you know, like it's considered to be a virtue. So children with autism often display these very high thresholds of pain. You know, they can get hurt really badly and they will not cry or comment about it. Like there's a kid, another patient of mine who got burned by an iron and he didn't cry. So on one hand, mostly it's hyper reactivity to pain. For temperature also, you can find children who in winters will insist on going and bathing in cold water. So these are all hypo and hyper reactivity to sensory inputs. So the C, D, and E criteria of DSM-5, which are mandatory, are C, the symptoms may be present in the early developmental period, and it may not become fully manifest until social demands exceed limited capacities, or may be masked by learned strategies in later life, which basically means that in early childhood, infancy, toddlers, you will find that the symptoms have been present. The second is the symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. So you can have parents who cannot take their children to parties, cannot take them to the market, cannot take them to the picnic because they have such temper tantrums or exhibit such unusual behavior that it becomes difficult for them to manage. So that is significant impairment. And the last but not the least is that these disturbances are not better explained by intellectual disability or global developmental delay or any other neurodevelopmental disorder. So there are certain other things in DSM-5 criteria, which I'm going to talk about later on. So we have two other extremes of behavior. One is hyperactivity. And hyperactivity is the reason why many people mislabel autism as ADHD just because of the presence of hyperactivity. And on the other extreme, you can have extreme passiveness. So the natural cause of autism, it's usually recognized by around 2 years.
With them all the time. Don't feel like doing.
Hello, sir, sorry, I can't. Sir, are you speaking with me? Shall I proceed? Okay. So the natural cause of autism, it usually starts getting recognized by 2. If it's severe, it's earlier, and if it's less in severity or subtle, it can manifest a little later. It's a lifelong condition, but the features, all these features that I just talked about, they will differ whether the child is an infant or a toddler or a child or an adolescent or an adult. And that's because these manifestations differ according to the chronological age, the cognitive maturity, the experiential learning which a child or an individual may get from, self-compensatory, self-learning or being taught during intervention, and the effect of reinforcement. Over the last many years, we have seen an increased prevalence. You can see this graph. It displays the CDC prevalence, and this has been attributed to increased screening, change in the nomenclature, increased awareness by clinicians, and yet to be identified factor, environmental factor that probably is seen more in people with certain genetic disposition. So an epigenetic factor still to be unidentified, but these things are under exploration. I'm not going to go into that, but I want you to focus on 2000. It was 1 in 150, and now in 2020 it's 1 in 36, and you can see the increasing trend. And that is why, coming to the crux of this whole session, is the American AAP, the AAP guidelines in 2020 came out with a statement that pediatricians should be competent enough to recognize, to evaluate, to establish diagnosis, to counsel, to help in families' decision-making, and provide continual support from the presentation at least till the end of its adolescence, and a smooth transition handover to competent authorities to deal with adults with ASD. And why is early detection important? Because early detection means early referrals for comprehensive assessment, confirmation of the diagnosis, and initiation of an individualized multidisciplinary intervention. An intervention which starts before 3 years has definitely better outcomes due to this beautiful gift that all of us have, neuroplasticity. And if a child's intervention leads to better abilities, then there's a significant cost saving. There are various reasons for delay for diagnosis. Parents may fail to recognize a problem, or they get that false reassurances that, the father was also like this, or they go into denial, or they keep on shopping from one doctor to another because they're not happy with the diagnosis. From the pediatrician's point of view, most of us are not doing universal screening. Secondly, if a child comes with some problem, often due to ignorance, we also give false reassurances, or the child may be mislabeled, or sometimes because the pediatrician is not sure and he's scared that the client may go off, he thinks, okay, let's wait for a couple of months, let's see how the things evolve. So in India right now, the prevalence as in 2011-12 was around 0.8 to 1.2%, which is almost the same as any other country. But we have various challenges. Holistic multidisciplinary management is not available everywhere, and if it is, it's costly, it's not easily accessible. And there are very few numbers of professionals who are competent in treating autism properly, given the wide or extensive number of children, and the quality is very heterogeneous. You can have developmental pediatricians, you can have neurologists, you can have psychiatrists from the medical professionals, you can have therapists, occupational therapists, physiotherapists, special educators, and even other therapists from the allied health professionals. You even have the Ayush doctors who are treating autism. So there's a very heterogeneity in the quality, and often comorbid conditions, often key situations, and routine pediatric issues get overlooked. So there may be poor compliance, because if things are not holistic, then the impact or the effect on the child may not be so good. So parents often are lost to follow up, leading to increased disability, and the quality of care, which is pretty plus minus in young children, becomes even worse as the child grows into adolescent and adulthood. So there's a very strong felt need in terms of medical health issues, in terms of social issues, in terms of educational issues for affected children and their families. So what are the challenges faced? We just talked about it, but primarily for pediatricians is a heavy patient load. There is lack of time, and lack of expertise. So I'm going to just briefly talk about a strategy that we use in Lady Hardinge Medical College, because all these things are applicable to us as well. And this is what I've been using with my residents, and we do find it easier for us to establish a larger number of children, the diagnosis in only by postgraduate residents and senior residents. So one is by staggering or scheduling the evaluation using a structured scientific approach and practice with feedback by competent authorities. The second, for the family, establish a rapport, listen actively, involve the parent, make him a critical key holder, proper counseling before you refer to the various people who are a part of the intervention. B, as a pediatrician, you should take the role of the team leader or the liaison person, and post-referral, when he comes back from therapist A, B, or C, explain by seeing the documents or by talking with them, explain it to the parents so that they do comply and provide support or guidance or resources. So there are various steps of evaluation. So the first is keeping a high index of suspicion. So during a health visit, look at the developmental profile, identify red flags. If you're screening an asymptomatic child and he fails, maybe the child has come to you for something completely different, and you observe that there's atypical behavior, or you have a child who has a sibling with ASD or who has a medical condition that is known to be associated with ASD. These are, you as a pediatrician should have a high index of suspicion. Sometimes the parent may come with that my child has some developmental problem or a scholastic problem, or may feel that there's a problem in the vision or hearing, or that there's a regression, or there's unusual play or behavior, or other medical complaints like recurrent abdominal pain, recurrent diarrheas that are unexplainable, or epilepsy and other stuff. I'll be talking about that a little later. Or the concern may be given by the teacher, and the parent has brought because the teacher has said that, look, your kid needs to be evaluated because of, again, atypical social interaction, communication with peers, poor scholastic performance, abnormal behavior, and in an older child, adolescent, may be indicators of mental health issues. So once you have these suspicion, then you go to step 2, establishing the clinical diagnosis. So the clinical diagnosis is like any other clinical diagnosis, yours with a history. All these symptoms, the onset, intensity, frequency, progression, and functional impairment, the symptoms due to the comorbid conditions, the past and the treatment history, the antenatal, natal, postnatal history, the family history, observation, examination, application of DSM-5 criteria. Now here, what I'm trying to tell you and show you is that all of us have been sensitized about ASD for the last couple of years. But here I'm trying to show you how to operationalize that knowledge into practical application in your office clinical practice. So in the first visit, so remember I said we're staggering the visit. So the patient comes with this impression that, you know, like pneumonia and diarrhea, that I'm going to get a spot diagnosis, spot management, and I'm going to go home. Wow, everything is under control. No. We all know that that is not possible, but we need to make the parent understand. So how do we do that? We involve them in the process. So the first visit, find out the concerns, who was the source, try to categorize these concerns, developmental, behavioral, neurological, any other, establish rapport by just listening. Listen and keep on noting. And if issues emerge, you know, by the hand, this is important. Maybe, but the parents, not the parents' concern, but you think it's important, just note it down and you'll talk about it later. Start with familiar ground in the history, you know, antenatal, etc. You know, so this is all something that the parent is comfortable with, and he, you know, you're conversing with him. So he feels, you know, that it helps in the making of the rapport. And then you do the look at the developmental profile. From the onset till the current functioning and all the domains, look for whether it's age appropriate or not, delay or dissociation, and what is the pattern. So the pattern can be 2 types. Either the child may have delay in all the 4 domains with significantly more in the social and language, or you can have gross motor and fine motor, which is absolutely fine, and social and language that are delayed. Now over here, we're not looking, I'm not asking you to apply a developmental tool. I'm just asking you to make a bedside clinical evaluation. In history, you're asking the milestones. Dr. Ashish Sani took a wonderful class on milestones a couple of weeks ago. And from the milestones, you kind of establish a crude, rough developmental age dependent on the last milestone that has been attained and the next one in sequence that has not been attained. So once you have understood the developmental profile, you do the examination. Anthropometry, abnormalities in height, weight, head circumference. So you can have obesity, you can have undernutrition due to these the dietary issues. Dental evaluation is very important because most of these kids, it's very difficult to get them to brush their teeth. Micronutrient deficiencies, dysmorphism. Around 20% of kids have some element of dysmorphism, even if they're not syndromic. And if they are dysmorphic, also look at the parents in the SIBS and just jot it down that we may need to have a genetic evaluation, neurocutaneous markers, look at the neurological examination, do a bedside developmental assessment just to confirm whether the milestones that the parents have told you about are actually true or not. Then a systematic examination. Diligent observation, social interaction, non-verbal, verbal communication, play, behavior, response to sensory stimuli, following instructions or not, and how the parents respond to the atypical behavior of the child. This all must be done silently in the clinic while you are doing other stuff, talking with the family. You're doing it parallel and you're jotting things down. So this is the 3-year-old boy who came to me. This is the OPD card of his first visit. I've just always determined the age, the age. I always write down the parent's name and educational level, because then if I talk with them and address them by the name, that helps them. It helps me to establish rapport. And if I know what their educational level is, it's easy for me to explain it to them in terms or in context which they would understand. Whether it's a nuclear or joint family, note down all the records that you want to review. Like over here, I wanted to look at the birth record, so I just written that down. Look at the comorbid conditions, look at the functional impairment, and whether the child has significant threat to himself or others. Check for immunization, screen time, diet, junk food, and all these things are written over here. Then the second is again the developmental profile, which I just talked to you about. So these are the milestones, and the gross motor is fine at 3 years. He's jumping. Fine motor is plus minus. He's started scribbling at 2. He still hasn't come out with lines. Language is definitely impaired. He has only 2 or 3 meaningful words, mainly people's names, mama, papa, and dudu. He has jargon, he has echolalia, and he can identify, he understands the names of colors and shapes, but will not say it. And social, the child does not, the child has a stranger anxiety was delayed, and he does not play with other children, and his waving bye-bye also came late. So this is the developmental profile. So there's definitely more impairment in the language and the social. So now the second step is, now again, as I said, we have to get the parents involved. So I give them homework. What is the homework? I ask them to write answers to 2 questions. So the first question over here, and this is in Hindi. So I write it down that आपका बच्चा एक हम उम्र लड़के के तुलने में क्या-क्या नहीं कर पाता है. So that is the first question. So I'm looking for deficits. And the second question is, आपका बच्चा क्या-क्या हरकतें करता रहता है जो आम तौर पे दूसरे लड़के नहीं करते. So here I'm looking for excessive behavior, and you must tell them, especially if the parents are educated, that look, this is the question which is taken, for example, in your exam, you had a 20-mark question. It has to be as in depth and as detailed as that. The second thing is that you ask them to make short home video clips. Now that has become so easy nowadays because almost every family has a smart home. So I ask them to make, for play, ask them to make videos which are at least 6 to 8 different types of toys or objects which the child likes to play with his siblings, play with children in the park, social interaction with other members of the family, any unusual behavior that the parent feels is a little atypical, any repetitive activity, and how the child eats. You can ask them for activities of daily living, but be careful because sometimes what happens is that they bring the videos of the child bathing, and that can be a little uncomfortable. So you can ask them checking questions to make them understand, to make sure that they've understood what you want. You can show them templates from other patients to, again, for the same purpose. Because what happens is the next time when they come and if they don't bring that information properly, and you also tell them that, look, and you write it down. I write it down in the card that, look, if you do not bring this information, then I will not be able to proceed with the evaluation, so that they understand that you mean business. So now by the end of the first visit, you have listened to the patient, you have got their primary concerns, you've jotted down things that you want to explore as the physician. Now also you can do the anthropometry and general physical examination. I did not do it here. I scheduled it for later. Investigations and management for things that have come apparent from whatever you have. So usually if there's suppose anemia or something like this child instantly had a record of vitamin D deficiency. Plan for the next visit. And anything else, like for instance, this child, a 3-year-old, he had come to us because he had a bout of diarrhea around 3 weeks prior to coming to me, and he was hospitalized, and the doctors there told the parents that, look, your child has a problem, take him to an expert. Before that, they were, okay, somebody was saying he's fine, somebody, that kind of stuff. So I've written over here, you can see here, healthcare seeking behavior 1/20 for the mother and 1/20 for the father. So I'm not being judgmental, but I'm again trying to establish that we mean business. It's time to be serious, and we have established rapport. Gappe maar rahe, converse kar rahe, but also at the same point, you have to be firm. So the second visit, the goal is to review the answers and the videos. Here for communication, we look at the quality, frequency, content. For the non-verbal communication, you look at the things that I talked about in the video. For social interaction, we look at how the child is initiating and responding to children and adults. The behavior, we're trying to categorize it, excessive or deficit, the severity, the triggers, and how harmful it is to the child and others, and response to sensory stimuli, increase, decrease, play with toys, activities, etc. So this is what we're going to get from the answers. So you can see here, they have brought stuff, and it's like, like when you take history for diarrhea, you ask them the chadast hai, kitne din se hai, and according to whatever answer is being given, you ask other questions. So the same thing applies over here. They've written over here, bol nahi pata. And I have written that cannot speak as compared to peers. Vocabulary words are usually of names of people and says dudu. And then they've written that kisi ke saath jaldi se apne baat mixed up nahi hota hai. Over here, I've written that he has problems with mixing up social interaction with people he meets for the first time, which is more what emerges here, that it's more in adult men rather than adult women. Similarly, he does not play with other children in the park. He stays at the periphery. The mother feels that he's uncoordinated, is clumsy, keeps on falling. Although he's been walking for almost 1.5 years, he cannot indicate his bowel bladder. In school, he has started going to school, and he can go to the toilet when he's taken by the attendant there, but not at home. He does not indicate hunger or thirst, and he has these ritualistic behavior according for food. He will not eat dahi in any form. He will not touch food if dahi is placed there, and he will not eat certain sabzis. Again, if those certain sabzis are there, he will not eat. However hungry he is. The second thing is, again, for the second question, out of which what emerged was that he snatches balls from other children in the park. He has repetitive play with colors and with sharpeners and rubbers. He puts them in and out of the box. He likes looking at books. He can't name the objects, but he keeps on indicating to his mother that for pictures of vegetables and animals, vegetables and fruits, and he keeps on indicating the mother that you tell the name, though he will not repeat it if she says it. And he likes pouring water from one bucket to the other, putting switches on and off. So this is what we've emerged. I'm not going to go through all these videos for lack of time. This is his language.
टेस्टिंग कराएगा कौन? बुला लो सबको, सारे फ्रेंड्स को बोलो, कम फ्रेंड्स कम.
So this is jargon because it's meaningless, but it sounds like a language. Over here, you can see again, okay. This is with a ring stacker.
Green, yellow, orange.
So you can see
red,
that he understands the colors
yellow.
of colors. So his cognition is pretty good, although his language isn't. And here, this video basically shows him again at the periphery, like the previous video. This I'm showing you his play with things going in and out of the box. He has these ice cream sticks which belong to his sister, and he loves playing with them. This is an example of playing with a part of the toy with a xylophone. He's mousing the stick, and he's playing with these buttons. Normally, you all know how a child will love to play with a xylophone. This is again, he plays with only with the wheel of the tricycle. He doesn't actually play with it. He doesn't like moving in it. And here, this is what the mother had said. that he doesn't like playing with children, but if he sees any child with a ball, he will make a beeline for this. Here in this video, this is what I noted in the thing. Again, he was very cranky, but he liked this thing. But I want you to look at this. Okay. So this was something that I had been trying to get him to do because I wanted to see the quality of his non-verbal communication. And one favorite thing of mine is asking ki pankha ka hai. So when I asked him, he did not respond for almost half an hour. But when the mother asked him, then did you see, that was immature pointing, not with his hand, just looking up. Then again, this.
Atharv, bye.
So now he is going.
Bye.
And he is responding to his name.
Atharv.
And he is looking at me. So now in the third visit, we've reviewed additional videos. The mother had said before that he had some issue with sleep. I've asked them to make a sleep chart. I reviewed it. It was fine. I performed the general physical examination and anthropometry, saw that there were some issues with the cranial contour. And so we noted that we have to do the head circumference charting, and we have to maybe do a formal evaluation of the craniosynostosis. Possible. Since the child had been in a uniform in the first videos, I had asked the mother to get some written notes. I written a letter to the teacher and I had asked for her feedback. And this is the feedback that I got from the teacher, because remember what I told you, multiple contexts, we need to know how the child is performing in school. Then based on the clinical information that I had obtained by the third or the fourth visit from the history, examination, observation, videos, answers, I had got enough material to see that he fulfilled the DSM-5 diagnostic criteria. All 3 of A were fulfilled, 3 out of the 4 of B were fulfilled. The only thing that was not very evident was the hypo or hyper responsiveness to sensory stimuli, and C, D, E criteria were fulfilled. So once you have used the strategic approach to establish the clinical diagnosis, you look at the comorbid conditions. So these can be medical. Around 30% of them have cognitive impairment, epilepsy, and around 25 to 30% sleep problems, GIT problems that I had outlined earlier. Psychiatric comorbidities, ADHD can be seen, developmental coordination disorder. And this is something that we thought may be seen in our kid also. That needs to be explored further. Anxiety, mood disorders, OCD, these are more evident as the child grows older. There are certain genetic and metabolic disorders, neurocutaneous syndromes, and others that need to be looked at. Environmental congenital rubella, antenatal exposure of the mother to valparin, and maybe other teratogens. So, sorry. There are certain other mimickers that need to be excluded, which may have an autistic-like picture, but not autism. Nutritional deficiencies, severe acute malnutrition, infantile tremor syndrome, excessive screen time, very, very common nowadays, virtual autism, environment deprived of social interaction and language, unidentified hearing and visual impairment, emotional, physical, sexual abuse. And these are the differential diagnoses that I am not going to go into, because this is for the level of a developmental pediatrician. So the third is planning tests as per indication. So assessment of hearing and visual, structured formal testing is essential for all children. EEG if there are seizures, regression, poor sleep or loss of sleep pattern. MRI if there's an epilepsy, microcephaly, focal neurological deficits, dysmorphism, or evidence of a neurocutaneous disorder. Evaluation of a dysmorphic child by standard protocol. Screen for anemia and nutritional deficiencies because they do have these food issues. Screen for their sleep and the dietary intake, just in case the child may require melatonin if behavioral modification doesn't work. Lead studies if there's significant pica or there are risk factors. And genetic or metabolic if suspected, but it needs to be consulted with an expert. So these are additional evaluation that has to be done psychometric by a clinical psychologist. As I said earlier, the diagnosis is absolutely clinical, using either the DSM-5 criteria or the ICD criteria. But there are autism-specific instruments that like CARS2, ADIR, ADOS that help in extracting more information in a more structured manner, so it can help you in planning the intervention. So these evaluations are really important because by assessing the cognitive level, the level of communication, the sensory processing, academic status, and adaptive behavior, or how he functions in his everyday life activities of daily living, we can determine determine what is the existing skills or strengths of the child. We can find out what he is weak in or what is completely non-existent, and what are his special interests that will help us motivate the child. And accordingly, and in addition, even the emotional and behavioral regulation. And this helps us plan out an individualized educational plan or the management plan. And you must remember that every autistic child is completely unique and different, and no one size fits all formula is applicable. It has to be totally customized. So after we do that, we plan referrals. So these are the various referrals: a developmental pediatrician or pediatric neurologist or psychiatrist to confirm your diagnosis, define the phenotype, and the more in-depth evaluation. And after intervention has been given, if there are still some issues, then the developmental pediatrician will decide whether psychopharmacology is required or not. The clinical psychologist for the psychometric evaluation, behavioral modification. Now, all these people outlined here have numerous responsibilities. I'm only like touching the tip of the iceberg for want of time. The speech and language pathologists, occupational therapists for independence, trying to gain independence in activities of daily living, the special educator, geneticists and psychiatrists, optional if required. So this is the multidisciplinary team. The goals of management for every child and family is to minimize the core deficits as far as possible, maximize functional independence, eliminate problem behaviors that interfere significantly with function, facilitate learning, either both non-academic as well as academic, management of comorbid conditions, promotion of positive parent-child interactions. So we have to ensure that the parents learn how to not reinforce maladaptive behavior inadvertently, which is often the case, and how to promote positive interactions, providing a safe and secure environment so that there is no accident or hazard, especially because children with autism have complete, they're not aware of hazards. Even at the age of 5 or 6, they can, it's not intentional risk-taking behavior, but they just are completely oblivious. And also proactive preparation for transitional phases, like from preschool to school, school to higher levels of school, adolescence and adulthood. So in an older child and adolescent, I'm not going to go into this because we're really running out of time. So I'm just going to synthesize my child. The diagnosis was autism spectrum disorder. How we arrived at it, you all saw. The severity, which is another part of DSM-5, is how much support the child needs, and in both the core symptoms. So this child requires support for repetitive behavior and substantial support for social communication without intellectual impairment, which will be confirmed by the psychometric testing, with language impairment, which again will be confirmed by a structured evaluation. With an associated medical, the child had vitamin D deficiency, genetic possible cranial synostosis, which we'll explore later on, environmental factor, very poor parenting skills, which will be managed by behavioral modification. With another neurodevelopmental, yes, maybe developmental coordination disorder, again needs to be explored. Mental or behavioral disorder. With catatonia, no. So this is the way you make a diagnosis of a child with autism. So it's like to draw a parallel. It's the way when we do it with RHD, with MR, with TR, with congestive heart failure, with arrhythmia, etc., etc., etc. So these are the ways you go about it. So the last but not the least, formulation of the management plan. We counsel both parents together, never counsel a single parent individually. This happened like almost around 15 years ago. I counseled the mother because the father was not coming, and then the mother became hysterical. It was very difficult to manage her. So make sure that both parents are together so that they can act as a support system for each other. Document everything in a language that the patient understands. Ensure that the referrals and tests are written in the management plan. Check their understanding. Stagger it with them so that they're not overwhelmed, and schedule the next visit after 2 to 4 weeks and tell them, even if you haven't completed your stuff, still come back to me, so that you know at least that they're on track or not. So we've planned the referral. So the last is counseling and keeping the child under follow-up. So remember, as a pediatrician, you need to be aware of all this stuff, but we do not want you to be an expert. But In the management plan, you have the behavioral modification therapy, you have speech language communication therapy, you have occupational therapy, you have special education, you have psychopharmacology. So here we just want you to familiarize yourself, and if the developmental pediatrician or somebody has started it, you need to be aware of the side effects, because then you'll be monitoring the compliance and the side effects of these drugs, management of the comorbid conditions, parental counseling, checking of understanding, because you are the person who the parent and family trusts. They are wary of the therapists. They are wary of the developmental pediatricians. Those people are viewed by the parents with skepticism initially, and it takes time for them to understand once the impact arrives. So you are the person at the crux. So you need to be the team leader in the beginning. Just ensure, again, since there's such a heterogeneity of quality of intervention, is the therapy individualized to the child's developmental level? Is it multidisciplinary, holistic? Are all the angles being covered? Is it family-centered? Is it easily accessible? Is it frequent and intensive enough to cause an impact? Is it being adhered to? And if it's not, why not? Is it feasible? Are there economical issues? Are there things that can be worked upon? So those are things that you need to do as a pediatrician. So there are strengths and challenges in this approach. We have been using this approach, the staggered, and it works fairly okay. Documentation brings clarity to the treating pediatrician as well as to the parent. The parent becomes actively involved. It's a systematic, structured, evidence-based approach. It ensures feasibility. The answers can be used in planning management. The videos can be used to explaining symptoms to other family members, like a dadaji or a nanaji who come and say, my bacha is absolutely fine. Why are you talking about these things? Sometimes if they want to seek a second opinion, it also helps. And it also helps in monitoring. Subtle differences may not be apparent, but you can show them the differences in the videos. What are the challenges? Sometimes the answers and videos are not written properly, so you can't proceed with your evaluation. So you have to show the parent how to do it properly and add an additional visit. For you as a person who is learning to establish a diagnosis, it requires complete commitment for your self-growth and development of competency. So obviously, you will need to practice, you will need to get feedback, you will need to, read up, substantiate your learning. And initially, it may be difficult to find a network of professionals who you can trust and who you can network with and get feedback from, but it is definitely doable and you can do it. So what are the roles and responsibilities of a pediatrician? Screen, you can use MCHAT RF, suspect, evaluate, refer, counsel, dispel myths. So these are the common myths, that it's due to vaccination. No, it's not. You often find children who have been advised to avoid wheat, avoid milk. Please discourage this. The children already have problems with their diet and they end up with these horrible nutritional deficiencies. Coenzyme Q10, omega-3 supplementation, there is no concrete hard evidence. It's very expensive. Mega vitamin shots, B12, B6, again, stem cell transplants, hyperbaric oxygen. These are all things that have no strong evidence at all and should be discouraged. Create a list of multidisciplinary service providers in your area. Ensure that the patients receive all routine pediatric services. You should not have a child coming to the hospital around 12 times in a year and is unimmunized or has anemia or has undernutrition. And these things do happen. You be the team leader between various professionals. Give proactive support during the transitional periods. Advocate, empower families, refer them to social workers, parent support groups, places where they may receive funding, direct them for disability certification. There is something called a unique disability card. Show them the resources. Remember that the family, apart from the child, also requires support, siblings, parents. So again, you don't have to do it as a one-man, team. You have to just show them, tell them, do this, this would be good, it will be helpful, etc. And there's this beautiful site by the National Trust. National Trust is a national government body which caters to families, persons with autism, CP, intellectual disability, and multiple disabilities. And these are a couple of the services that may or may not be available according to the residential area, but which are applicable for children with autism. So this can be explored. And to end up, the key messages that if there's a very strong need for us, the community of pediatricians, to step up for these families. Why? ASD is common. You do need to keep a high index of suspicion. It's easy to establish diagnosis by history, examination, observation, application of the DSM-5 criteria, especially if you're using questions and home videos, and you use the systematic approach with staggered visits, involving the parents, have clear documentation, make appropriate referrals and obtain feedback. Be ready to be the team leader or the liaison officer, help in counseling, planning management, monitoring, checking adherence, parental education, and advocacy, help in the transition periods. Provide continuity of care from presentation whenever the child comes to you, from the first time through adolescence to adulthood. Sometimes these families just need a person to, talk to, just to, listen and, just hear them out. It makes a world of a difference. So I end by saying you can do it. All of us can do it. Just believe in yourselves. And I really thank you all for your patient listening, and all the patients and their families for giving me permission to use their clinical details for the educational purposes. Thank you so much. I'm stopping the sharing right now.
Thank you very much, Sharmila, for this excellent overview. And as usual, you have done a brilliant job. May I request Dr. Kunju and Dr. Roma for their comments and any expert opinions?
I think, Dr. Sharmila, you've done a wonderful presentation. You've explained everything so well, to the detail, to the T. Everything was very well explained. And I'm sure the pediatricians would be able to pick up many of the areas that you pointedly showed on the videos, and very clearly, labeled them that what area can be picked up like this and which area cannot be picked up. So I think it was a beautiful, wonderful presentation. Nothing more to say, but
Thank you,
were too good. You were too good.
Dr. Kunju?
Thank you.
Actually, again, Dr. Sharmila's presentation was excellent, because initially I thought that she'd be, as usual, she'd be giving only the clinical features for the diagnosis of both the pediatricians and others. But after the initial presentations of the clinical features, she has gone into the actual management of the case scenarios, which was really a pleasure to watch and to listen, and how she has brought in the children, and with the help of the home videos, how she could follow up them. I think those points were definitely useful for all the pediatricians, developmental pediatricians, pediatric neurologists, all were watching. As mentioned, there may be a lot of role for pediatric neurologists in the autism spectrum disorders, because most of the comorbidities Dr. Shamla has described actually pertain to pediatric neurology. So the pediatric neurologists will be called in to manage those aspects. Plus, I think they are also well versed in assessing, diagnosing, because early diagnosis, always tell that though early diagnosis is very, very important, because even American Academy of Pediatrics and all other associations try to make a diagnosis or a confirmed diagnosis by 3 years only. By the time, you know, that the time for development of speech, development of socialization are also over. So actually, we must diagnose these children before 6 months itself, because as a pediatricians, when we are following up them, especially in the well-baby clinic, where the immunization is given and assessment is being done from first month or 6 weeks onwards. Actually, 6 weeks itself, the social smile will start. So if at least some evidence of social smile is not there by the first immunization visit, then I think there should be an alarm bell ringing. And next month or by 2 months, there should be social smile. And by 3 months, actually, the child starts speaking. the 3 months. So where the mother or the pediatricians can interact with the child, talk to the child, and we'll see that they are using ing, ang, and responding by puckering the lips. That means the actual communication has started. And at that time, so there will be a strong social smile, and by the end of 4 months, there is laughing aloud. So that means all these are communications, socialization behavior. So observant parent and observant pediatricians must identify these developmental abnormalities and start thinking. And by 6 months, the object permanence, that also must develop. So all these are early pointers, and one must make a diagnosis by this time. Means you don't give a label it as ASD, but developmental problem with some red flags. And so actual simulation, if you start, I have seen that most of these children improve if early intervention is done. So one point that has to be remembered is that we have to make a diagnosis as early as possible, at least suspicion, and start managing it. I think that is one point I have to make. But anything else, I think the moderator can add in, and I think we can conclude that. Hello?
Yeah.
Okay, shall we, Dr. Rama, shall we conclude, or your
we have Dr. Lalan Bharti. If he can put in some. Dr. Bharti? Dr. Lalan, are you there? I think then we can conclude, sir. Thank you.
Okay. Thank you so